So pretty important content, people, you should never forget. For a fetal skull, the longest diameter is mento-vertical diameter, and second longest is your submento-vertical diameter. And face presentation is always seen in your submento-vertical and the submento-pragmatic. Diameter is your engaging diameter. Okay, so the face presentation is most common in anencephaly. Another pretty important MCQ you should never forget, because anencephaly is a condition where the patient do not have any sort of a head development proper. So improper development of the head, which in turn makes the baby to show their face first. Bro. Hmm. Okay. So next important diameters are your transverse diameter, that is MTSP, bimastoid diameter, bitemporal diameter, super subparietal diameter, and biparietal diameter are your four transverse diameter. Another important high yield thing you have to know is your stages of labor. First stage of labor, from the onset of pain to cervical dilatation complete. So first stage is again divided into latent and active. Pain to 5 centimeter cervical dilatation, it is first latent stage. 5 centimeter to 10 centimeter dilatation, it is the active phase. Okay. Second stage is cervical dilatation to expulsion of your fetus. So in the case of a primigravida, it is 1 hour. In the case of a multigravida, it is 30 minutes. Okay, the second stage is 30 minutes. And in the case of a third stage, expulsion of fetus to expulsion of placenta, without active management of third stage of labor, it is 15 minutes. With the active management of third stage of labor, it is 5 minutes. Without active management of third stage of labor, 15 minutes. With the active management of third stage of labor, it is 5 minutes. So post-operative period of post-operative observatory period of 1 hour is your stage 4. That is after your delivery is done, that is your labor is finished, you have to observe the patient for 1 hour. So the post-operative observatory period of 1 hour is your stage 4. So next pretty high yield thing you have to know is your cardinal movements of labor. Cardinal movements of labor are your engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation, restitution, external rotation. So all of the components are your AMTSL except. So the mostly they will give you uterine massage, because previously uterine massage was a component, but now it is not. So you should remember uterine massage is not a component of active management of third stage of labor. Use of oxytocin is indicated. Most of the people uses use of oxytocin. So don't do that mistake. Next, anesthesia. Anesthesia, you will do pudendal nerve block. Important thing you have to know is your sacrospinous ligament will be pierced there, and the nerve root is S to STS4. And the Bishop score modified, pretty important, high yield. Maximum score is 10. Dilatation, position, length, and consistency. Cervix dilatation, position, length, and consistency. You should never forget. Dilatation, position, length, and consistency. Okay, DP looks cute. You should never forget DP looks cute. Okay, so DP stands for dilatation and position, and L stands for length, and C stands for consistency. Okay, and you have your fifth parameter as your head station. Head station. Okay, so you should never forget that. Okay, next important thing, because the Bishop score modified will be asked, all of the following are components except. And contraindication of induction of labor are your macrosomia, hydrocephalus, infections like HIV, herpes, placenta previa, contracted pelvis, cord prolapse, uterine scar, transverse life. So remember, with the mnemonic, my hip continuously transport pain to uterus. My hip continuously transports pain to uterus. So M stands for macrosomia, H stands for hydrocephalus, I stands for infections such as herpes and HIV, and P stands for placenta previa, and C stands for contracted pelvis, and T stands for transverse lie, and P stands for cord prolapse, and U stands for uterine scar. Okay, uterine scar means like a previous cesarean sections, etc. So next is your postpartum hemorrhage, pretty high yield. We will discuss only the high yield content. Most common causes uterine atony. Within a 24 hours, it is uterine atony. After 24 hours, it is your retained placenta. Okay. Shock index, they asked you one time, like a heart rate divided by systolic blood pressure. Greater than 1.1 indicate resuscitation. And obstetrical shock index greater than 1 indicates your massive blood transfusion. High yield MCQ. Adherent placenta, only the variants are important. Placenta accreta, increta, and percreta. Next, you have your malposition. The two statements you have to know your malposition is most common is occipito-posterior position, and most common mal presentation is your breech presentation. And next important topic is your obstructed labor. Two statement, people. You should never forget these two statements. So obstructed labor, never ever wait and watch. Never ever give oxytocin, because obstructed labor is emergency. You have to act immediately. You have to open up and you have to do your C-section immediately depending upon the situation. So there is no wait and watch. Most of the exception will be wait and watch. Often you get confused with that and you choose wait and watch. No wait and watch in obstructed labor, and no oxytocin in obstructed labor. Okay, so all of the signs of obstructed labor are pretty high yield. Bundles ring will be seen, rupture of uterus will be seen, loss of station will be seen, and absent uterine contraction will be seen. Hot and dry vagina will be seen. Fetal bradycardia and maternal tachycardia will be seen. Okay, management is always C-section. And intrauterine life, signs of intrauterine death is important. Intrauterine death signs are, number one is your Roberts sign, that is a gas in your great vessels. Gas in your great vessels. And you have your skull, overlapping of skull, that is your Spalding sign. Important question, all of them are important question, people. Spalding sign, Roberts sign, Hagar sign, Oslander sign are pretty high yield signs you need to remember. And lemon and banana sign, nuchal translucency, dosage of folic acid, everything is pretty high yield. Cardinal movements of labor, and ball sign is a hyperflexion. Okay, these are the important signs of your intrauterine death. Robert sign, or they may give you gas in the great vessels indicates immediately within a second you have to put intrauterine death. You should never choose the other thing. Okay, next important thing is your abortion. Live fetus on USG means it is a threatened abortion. Empty uterus on USG means it is a complete abortion. And internal OS, ovarian sphincter, is seen in, sorry, is closed, is open in inevitable and incomplete abortion. Cervical internal OS will be open in inevitable and incomplete abortion. And dirty brown discharge, open, sorry. Rest all abortion, it will be closed. Dirty brown discharge is seen in missed abortion. Okay. The most common cause of your spontaneous abortion is your chromosomal anomaly. And on the chromosomal anomaly, the most common one is your aneuploidy. Two important MCQ. Okay. And most common cause of your recurrent abortion is your idiopathic. That is unknown. Next, antiphospholipid antibody syndrome. You will study that in a medicine. I'm gonna hear only the associated with the second trimester pregnancy loss. Okay, and the anti-cardiolipin antibody will be seen. Okay. Next, you have your medical termination of pregnancy act. MTP Act, the important highlights are there is no role of husband in termination of pregnancy. That is, even though the husband do not want baby, but the wife wants a baby, legally the wife can have the baby. So even though the husband says that I don't want the baby, abort it, husband has a no role to play. But if wife don't want the baby, she want to abort it, and husband wants a baby, then the baby will be removed because no role of a husband plays a role here. Okay. Next, termination is done in only in a government hospital or government recognized hospital. If they wanted to do in a private hospital, then they have to get an approval from your CMO of a particular district. That is a chief medical officer of a particular district. Next, uh, the for abortion, normally the consent of the women is required. Okay, it need not to be like a written consent. If the patient says like I am 18-year-old, then that is fine, and I wanted to abort, then that is fine. So the consent of women is required, but it is not a mandatory that a written consent. Okay, from a women. But if she is a minor, then the guardian's written consent is required. Then, if the patient is minor, or we can also say the patient is not only a minor, not only minor patients, mentally ill patients. So the patient is either minor or mentally ill, then she requires a guardian's written consent. Okay. So the final important highlight is if the pregnancy is 12 to 20 weeks, it have a more risk of both maternal risk as well as a fetal risk. So what you have to do is two doctors must approve for the termination of pregnancy. So these are the important highlights of your MTP Act. There are a lot, but I am talking about only the important highlights of your MTP Act. Next, we are doing about your medical abortion regimen. That is a government approved one. If the abortion is done before 7 weeks, then day one you have to give mifepristone of 200 mg oral and tell the patient to come back after 2 days. And when the patient visits you on third day, you have to give a misoprostol of 400 mcg. Okay, and you have to observe the patient for 3 hours, and then you have to tell the patient to visit after 2 weeks. So once after 2 weeks, at the 15th day when the patient visits you, you have to check for the complete expulsion of your fetus. Is there any fetal material is or fetal tissue is inside the women's birth canal? Okay. But if the abortion is happening between 7 to 9 weeks, then you have to then the day 1 and day 15 are similar, but day 3 will be different because the day 3 you have to give vaginal mesoprost 800 mcg, vaginal mesoprost of 800 mcg. Okay, what is the best method of abortion? If the termination have to be done before 7 week, medical termination is a good one. Okay, and if it is 7 to 12 weeks, suction and evacuation is the best method, and greater than 12 weeks, prostaglandin therapy is a best method. Okay, all these are pretty important and high yield MCQ, you should never forget. And next is your ectopic pregnancy. I'm gonna talk about the ectopic pregnancy only a few things. Number one is your most common site, that is ampulla of your fallopian tube, and most common tubal abortion site, it is ampulla again. But a tubal rupture, it is isthmus. So tubal rupture, isthmus, tubal abortion, it is ampulla. And gold standard treatment for ruptured ectopic pregnancy, that is salpingectomy. And gold standard treatment of a diagnosis of ectopic pregnancy, that is laparoscopy. So diagnosis of ectopic pregnancy is always laparoscopy, and gold standard treatment for rupture, it is always salpingectomy, that is surgery. Okay, placenta previa. Important one is your Brownies classification. They classify the placenta previa into four types: type 1, type 2, type 3, type 4. Lateral, marginal, incomplete, central, and is complete central. Among them, type 1 and type 2 are minor degree, and type 3 are your major degree. So the MCQ here is, what is the dangerous type of placenta previa? That is the type 2 posterior type, because type 2 is again divided into anterior and posterior. Type 2 posterior type is your more dangerous type. And no, never ever do the vaginal examination in your placenta previa. Never ever do it. And regimen which is used for your uh, uh, the regimen which is used for your placenta previa is McAfee and Johnson regimen. And next you have to see your abruptio placentae. Most common type is mixed type. That is the only thing you have to know, remember. And twin pregnancy also, twin peak sign or lambda sign is seen in. Dichorionic twins, high yield MCQ. And the twin transfusion syndrome is always associated with monochorionic placenta, another important MCQ. So the management of your twin pregnancy is important. So if the first and the second twin are cephalic version, both do the vaginal delivery for both of the babies. If the first one is your cephalic version, but your second one is your longitudinal lie, then do the vaginal delivery for your first baby and do the cesarean section for your second baby. And if the first is cephalic and the second is transverse lie, then do the vaginal delivery for the first baby and do the internal podalic version for the second baby and make it into the normal breech and then deliver the baby through the breech extraction method. So pretty high yield MCQ, they will ask you in a case format. For example, they will ask you like the 26-year-old woman coming to your office, like Sita or Geeta, okay, and they were having a twin baby, and the ultrasound reveals that the lie of the fetus is cephalic for the first and transverse for the second. What is the next step in management? Internal podalic version and convert them into normal breech and deliver it through your breech extraction method. Okay, this is what you have to do. So this is how you have to answer the case question and application type of questions. Okay, diseases in pregnancy, diabetes, pretty high yield things only I am highlighting here. The most common system involved is your CVS, and the most common congenital anomaly is ventral septal defect, ventricular septal defect, and the most specific is your caudal regression syndrome, pretty high yield MCQ for MCI. And the most specific cardiac symptom is your transposition of great vessels, transposition of great vessels. And the very important thing is your fetal complication, that is a macrosomia. Okay, so hypertension in pregnancy, 20 weeks, greater than 20 weeks, and hypertension, it is called as gestational hypertension. Greater than 20 weeks plus hypertension plus proteinuria, it is called as preeclampsia. Less than 20 weeks plus hypertension after delivery, that is chronic hypertension. These are the important topics you have to know about your obstetrics and obstetrics. We will discuss about the gynecology later. Okay, so the important ones I gonna highlight for 4 minutes. What are the things you need to know? One spermatocyte gives rise to 64 sperms and 16 primary spermatocyte. And endometrium is after fertilization, after implantation, the endometrium is called as decidua. You know that decidua locations. And placental hormone synthesis is basically in a syncytial trophoblast. Most commonly they will ask your beta HCG, that is your syncytial trophoblast, you should never forget. And umbilical cord contains 2 arteries and 1 vein. And for amniotic fluid index is normal is 5 to 25 centimeter, less than 5 centimeter it is oligohydramnios, and greater than 25 centimeter it is polyhydramnios. And anencephaly, most common presentation you will see in anencephaly is face presentation. Physiological changes in pregnancy, you will see the weight gain and Menger syndrome, superior vena cava hypotension syndrome, supine hypotension syndrome, that is compression of IVC. Then you have your cardiovascular changes. What are the changes you will see? PVR decreases, BP decreases, and you have your oxygen gradient decreases. So restall parameters increases. Hematological, you should never forget clotting factor 11 and 13 decreases. Okay, restall clotting factor increases. And you have your dermatological linea nigra and colasma. See the pictures. And Braxton Hicks contraction is always seen in a second trimester. Softening of cervix, Gödel sign. Softening of lower portion of a uterus, Hagar sign. Softening of uterus after 6th week, that is your Laden sign. And regular rhythmic contraction on bimanual, Palmar sign. Bluish purple discoloration, Chadwick sign. Chadwick sign, mostly they will ask you whenever you see an obstetrical question with the bluish purple discolorization of vaginal mucosa, go with the Chadwick sign without any question, without thinking other thing. Okay, so the diagnosis of pregnancy, the most common one, most specific one is your first sign, that is gestational sac. So gestational sac is calculated by mean sac diameter calculation, length, height, width by 3, and yolk sac is first anatomical. Gestational age calculation, first trimester, it is crown rump length. Pretty very important MCQ. This is. And antepartum assessment, lemon and banana sign is seen in spina bifida. Nuchal translucency is seen in Down syndrome. Down syndrome is trisomy 21. Edwards syndrome is trisomy 18. All levels of your quad screening test are low in Edwards syndrome. What are the parameter increases in trisomy 21? Beta HCG increases and inhibin increases. On the normal and abnormal labor. So most common pelvis is gynecoid pelvis. Best method for assessment of pelvis is trial of labor. Radiological assessment MRI. And which pelvis have an anterior posterior diameter is greater than the transverse diameter, anthropoid. What is a contracted pelvis type? Nagellus pelvis and Robert pelvis are important. One ala absent, Nagellus. Two ala absent, it is Roberts. And measurements, important measurements is your smallest diameter, interspinous diameter, clinically assessed conjugate, diagonal conjugate, and the face presentation is seen in anencephaly. Longest diameter is mentovertical diameter in the case of fetal skull. For the stages of labor, you have to know about each and every stages, and cardinal movement is pretty high yield, you have to mug it up. And components of AMTSL, uterine massage is not a component. Uterine massage is always given as exception. So Bishop scoring system, DP looks cute. In fact, you can say Stella's DPs look cute because Stella stands for head station and DP stands for dilatation and position of cervix. L stands for cervical length and C stands for cervical consistency. So the maximum score of your modified Bishop score is 10. And contraindication of induction of labor, you have to see my hip continuously transmit pain to uterus. Okay, so PPH, postpartum hemorrhage, uterine atony is the most common cause. And obstructed labor, no wait and watch, no oxytocin. Restalled next. Gas in great vessel, IUD. Skull overlapping, IUD. Hyperflexion, IUD. That is a Roberts sign, Spalding sign, and Ball sign. Abortion, you have to know that the most common cause of spontaneous abortion, chromosomal anomalies. Pretty high yield in MCQ. Antiphospholipid syndrome or low yield. MTP Act, consent of the women is high yield. Two doctor approval is high yield. No role of husband is high yield. Medical regimen, you have to mug up the dose, people. And in the case of ectopic pregnancy, most common site is ampulla, high yield. Tubal rupture, isthmus, high yield. Gold standard diagnosis, laparoscopy, high yield. Next you have to know is dangerous type of placenta previa, type 2 posterior. That is pretty high yield. Regimen McAfee and Johnson regimen. And twin pregnancy managements are high yield. And what sign you will see? Twin peak sign or lambda sign. Diseases most specific with diabetes, that is your caudal regression syndrome. And most specific cardiac, that is transposition of great vessel. Most common one is VSD, and most common fetal complication is macrosomia. So these are the important thing about your obstetrics. We will